Good morning. This is Dr. Gabriel Chu from the Fraser Valley Cataract and Laser, talking about one of my cases, typical cases that I would do in my OR. This patient is scheduled for cataract surgery with a multifocal oculentis Mplus lens implantation, as well as an I-Stent procedure because he's got glaucoma. So I'm just going to do a quick narrative here, and I apologize for the resolution. It's a 720 resolution camera, so it's not the best, but you can kind of get a gist of what I'm doing here. I'm doing vertical and horizontal chop technique, rotating it around in a circular fashion to remove the pieces, the cataract piecemeal. And I don't really move my primary hand or the phaco very much. I use my secondary chopper to feed the pieces into the capsular or into the phaco tip. There I just removed I moved into epinucleus and removed the epinucleus. It is a LensX case, so you can see there's a perfect capsular rhexis, much more consistent, large and circular than what would have been made otherwise by hand. And you can tell that from the red reflex here. And the only thing that remains now, even though it's quite clear, is the red reflex is the cortex here. You'll see a strepping method where I go around in a clockwise fashion. It's always easier to remove and strip the cortex from an area where there's only adhesions on one side. So I always like to do it in a successive circular process. And then the subincisional I usually do last because there's the least number of adhesions after the rest of it's removed. Once it's nice and clean, I look for any wisps on the posterior capsule. If there isn't, then I'll re-inflate the capsular bag with cohesive viscoelastic. Countertraction with the 0.12 allows me to easily get into the eye with a tight wound at 2.5 millimeters. Here I'm using an injection style inserter to put in the Mplus lens. It does come out quite quickly, so I do want it to be right into the capsular bag. You'll also notice with my second hand, I had the chopper ready to push the lens posterior so that the trailing haptic goes straight into the capsular bag without having it hang out and then trying to rotate it in. It is quite a large lens with C haptics. Here, what I've done is just rotate the lens into a proper position, and I put viscoelastic in the on the nasal portion of the angle to expand the angle, as well as a little bit on the cornea. And the reason why I'm doing that is because I'm now preparing for the I-Stent, and for a minute the eye's going to be out of view. But what I'm doing is I'm rotating the patient's face away from me. And I'm also rotating right here, you can tell that the microscope is rotating to about a 45 degree angle because we're doing direct gonioscopy. And with my left hand, I'll have a direct gonioscopy that'll sit right on the cornea. And my right hand is where I'm going to plan on doing the insertion. I usually put in two I-stents, a right hand and a left hand stent. It's been shown in many studies that two or several I-stents have an additive effect on the decrease in intraocular pressure. It's also been shown in many studies that putting a stent in the trabecular meshwork reduces the pressure even more than just the cataract surgery alone. As we all know, cataract surgery does reduce the intraocular pressure simply due to widening of the angle and maybe different anatomical changes in the angle. And of course, the I-Stent improves that. So now after I have a direct visualization of the trabecular meshwork, and I can tell it's a trabecular meshwork because I can see the red tinge from the Schlemm's canal, the blood in there, and that is the left hand. We call it left hand because it goes towards the left, and then I'll do another one for the right side. Patient's very comfortable. It's a very safe procedure. The side effect profile of I-Stents is similar to the side effect profile from a cataract surgery because it's an ab internal procedure. We use the same incisions. We don't. It's not the same as a ab external procedure like a trabeculectomy. It can also be done at the same time as a cataract surgery, which is a benefit for patients. Now I've recentered their head, and I'm going to remove the rest of the viscoelastic. You may or may not see here, but because you have a direct canalization of Schlemm's canal, you may see, and you see a little bit of heme there. And that's expected and actually welcome, because you want there to be direct canalization from the aqueous humor through the trabecular meshwork into Schlemm's canal and to remove that point of resistance. So you will see a little bit of heme and maybe about a 1 to 2 plus microhyphema here. I got a little bit of floppy iris here. You see that iris there, so we're just going to sweep it back in and seal the wound. And once the wound is sealed, then that iris should come back in. Try to be gentle with the iris because it's very fragile and also very, very tender. So yeah, that's in a nutshell, that's my a typical case that I would do for cataracts with an Mplus lens with an I-Stent at the end. Thanks for joining us. It's Dr. Gabriel Chu from FVCL. See you next time. Bye-bye.